Hello and welcome to our webcast. I'm Amy Pendergrass with Moss Adams, and I'm going to get us started for today's session, The Future of Mental Health Telehealth Services. We're pleased that you've joined us today. And before we begin, I'm going to play our housekeeping video.
Welcome, and thanks for joining. We're pleased to present our continuing professional education webcast series. Before we begin, please keep the following in mind. You can customize how you view our presentation and interact with the presenter. For better viewing, close all other applications and turn up your speaker volume. You can adjust window size and placement or enter full screen mode using the controls at the top right of the window or dragging the bottom right-hand corner to resize. At the bottom of your screen, you'll see a series of icons that relate to a different aspect of our session. You can download a PDF of today's slides from the Slide Deck and Handouts widget. You can ask questions by typing in the Q&A window and clicking Submit. We'll do our best to answer all questions or follow up via email. If you experience technical difficulty, refresh your browser by hitting the F5 key. Today's session offers 1 CPE credit. To receive credit, you must meet the National Association of State Boards of Accountancy requirements. You must attend at least 50 minutes of the session and respond to at least 75% of polling questions. To participate in the polls, please check the button next to your answer within the slide window and click Submit. We'll track your progress and alert you when you've earned CPE credit. You can then click the certificate icon in the CPE Progress widget and download your CPE certificate. Don't worry if you can't download your CPE certificate today. We'll email you a copy in 2 weeks. If attending this webcast in a group, you must complete our group CPE attendance sheet, available in our Slide Deck and Handouts widget to receive credit. Please have all group members sign it and send only 1 sheet per group. CPE credit can only be awarded to participants registered as themselves and isn't available for participants who view the on-demand version. This presentation is not legal, investment, or accounting advice. We encourage you to seek the counsel of a professional service provider to apply this content to your specific circumstances.
All right, and now I would like to introduce today's presenters from Moss Adams. We have Lori Laubach, partner, and Kim Hodson, senior manager. Their bios and contact information are located in your webcast console if needed. And now I would like to turn the floor over to Lori to get the presentation started.
Thank you, Amy. And thank you, everybody, for joining us to discuss telehealth and how to identify any type of risk that's out there related to telehealth and within your organization. We all know that the public health emergency is ending on May 11th, and there's a variety of issues and things that need to be considered related to telehealth, and in particular with mental health. In addition, telehealth has taken a kind of a front seat to the concerns by the regulatory agencies, how it's being provided, and does it actually provide the quality of care that is necessary for those patients. And there's been a substantial increase in the number of patients and organizations that have adopted it. I'm Lori Laubach, and I'm partner with Moss Adams, as Amy was indicating. We spend in charge of the regulatory compliance and healthcare internal audit practice. And we work with clients related to compliance for over 20 years, but I've never become a certified coder. So from a coding perspective, I'll lean on Kim for that perspective. But we work with clients and help them with their audits, compliance, effectiveness, and internal audits. And then joining me is Kim Hodson, as Amy mentioned, and happy to have her as one of our team members leading the regulatory compliance projects that we have within our group. Our goal today is to talk about changes and updates and different modifications to the regulations. It's not really a technical coding presentation, but we thought we'd start with where we are today with telehealth. So we're going to have one of our first polling questions. And this polling question is really asking, trying to identify who we have on the phone, and please click one of the items that are listed here as mental health outpatient, inpatient, outpatient, and if mental health is one of our service areas or none that apply, and just so that we can identify who we have on the call today. We have a large group, and it's pretty exciting. There was interesting to look at some of the statistics as we were preparing for this presentation, and there's all these different numbers that are being touted out there. But it was interesting from throughout 2021 and into 2022, an entity called Fair Health was tracking the monthly trends. And if you look at the mental health conditions, about 58.9% of the telehealth claim lines nationally are up to about 55% in December 2021. By comparison, they were also number one among the telehealth diagnoses in 2020. So it looks like we're getting close to the number of attendees, but I think it's interesting to not just look at the number of telehealth visit CPT codes, but also to be looking at those diagnosis codes and tracking the percentage of those related to telehealth and how they're being treated. So it looks like we have a large percentage of the group that's one of our service areas, and running right behind that is that there's some that say that none of them apply, but they're getting education. So Kim, why don't you go ahead and go through the next polling question?
Yeah, so our next polling question is really asking how are those mental health services provided in your organization? So are they all in person? Are they telehealth only? Is there a hybrid split between having an in-person visit and telehealth visit, greater than 50% or less than 50% in telehealth? And then we have an option of none apply. So Lori, you were mentioning some studies that you were looking at in preparing for this presentation. I came across one that I just thought was super fascinating, published by the NCHS just recently, talking about the results of telehealth in 2021. And they mentioned that 37% of adults used telemedicine within the last 12 months. That just to me is fascinating. What a great time to be involved in healthcare, to have these new technologies available and just being able to reach patients where they are and provide that service without having to go into an in-person visit. So I thought that was super
It's very interesting for sure. Yeah, I'm just amazed at even my husband's on telehealth, and he's the most Black. He doesn't have technology in his background at all, or even knowledge.
Yeah. Oh, great. So it looks like we have about 50% that offer a hybrid model, with less than half of that being in telehealth. So great. I think a lot of this presentation will apply then to that group.
So now we're going to jump into talking about telehealth, telemedicine for mental health today. Before I jump into this, I wanted to touch on an article that I had read in the New England Journal of Medicine, where the author provided kind of some questions that it's not just focused on mental health, but focused across telehealth as a whole. And that's to ask Congress to maybe think about these as we start to look at ways to enter the, to extend, expand, or curtail the telemedicine. And the three questions they actually put together is, does it actually save money, or does it spend more? So it looks like, they're putting money and reimbursing certain populations such as rural health and certain conditions like acute stroke, but they're relying on the assumption that telemedicine is cost effective in these contexts than for other patients and conditions. It's just questions to think about. And is it actually safe? The next question is it safe to treat patients remotely? There's all different types of surveys, and they all come out with different types of results and trials that say that in-person care have found that telemedicine is a safe clinical option. However, these studies had an important limitation. They only looked at a small fraction of the telemedicine, and they were also looking at those situations where a patient is a hybrid, where they're both being seen in person as well as the treatment in on a telehealth perspective. So it's just really kind of looking at the, is it really safe? And that's on the, you hear that in a lot of the materials and information that you receive from the government. And the third question is whether it really advances health equity. This is what CMS is touting, and a lot of other regulatory agencies are discussing, is that it really provides that equity. And then the policymakers have said that they really want to make it easier for members of underserved populations to obtain care. And so there's less disparities in access and outcomes. But because of a digital divide, and I'm going to use that terminology in the sense that basically it means that there's populations that are underserved who don't have the access to the technology to be able to do the telemedicine. And so then what happens is the telemedicine is probably used by more advantaged patients. So there's some conflicting results related to that. So really thinking about your patient population and how they can provide access, get access to it. And so just kind of quickly, just to kind of go through where telemedicine is today. And I just wanted to level set a little bit. We hear telemedicine, we hear telehealth, we hear telepsychiatry, and I just want to make sure that, telemedicine is that process of the whole healthcare, providing healthcare from a distance through technology, whereas telepsychiatry is that subset of the medicine that, helps with that. And telehealth is the overarching, includes telemedicine. So it means that we can use more than just video conferencing. It's remote patient monitoring, it's other things like that. And it's really good, well defined by HHS on their website. I also wanted to bring out an alert that there was published on April 17th. CMS announced that they had proposed measures that'll make coverage for behavioral health more accessible. And it's through the 2024 Notice of Benefit and Payment Parameters final rule. That just got released, and I haven't had a chance to dig through the Federal Register, but some of the key areas is making it easier to enroll in coverage, increasing access to healthcare services for mental health, and simplifying choice and improving the plan selection. So kind of get out there and look at the different articles that are going to come out related to that, as well as if you want to read the Federal Register. But then just kind of thinking about, mental health today, I don't think any of these are surprises to the audience, but there has been, as we know, a major shift, as we talked about. But there's also the trend where the no-show rates have dropped. And I've heard this from a variety of organizations where patients are coming in because are afraid to come in, so they choose not to come in, or they have issues or they can't travel to the actual clinic to do the care. And so they tend to attend the telehealth visits more than they do. APA, American Psychiatrists, I think it is, noted that patient prefers being at their home during their telehealth appointment. And there's they show that their first-time appointments are probably not as satisfactory, but they do like to be able to be at home during those. And then they also talked about, being able to get more care and access to providers because of the ability to receive care from a provider in another state. We do know that there's some changes going on with the PHE ending and all the compacts being updated for licensing of providers across states, but it actually gives more access to the patients. And then audio also gives an option for patients who don't have that telehealth ability to get onto technology and doing video or camera or anything like that. And so those are just some of the things that have really we've seen is happening in mental health. And there's probably a lot more that we didn't list there. And then when we look at the benefits, some of the benefits that we see from there is there's access for patients that are in the rural and provider shortage areas. So we know some organizations where they've actually spent some time, reaching out to a telehealth only provider. During the PHE, there was, there's different sessions I've attended around where they used a dog sled in Alaska to get immunizations out to patients, but they were also taking out remote patient monitoring tools and things like that so that patients could actually, they couldn't travel in, so they needed to have an access to be able to do that, especially during COVID. And then the whole reductions in trips to the emergency room, having the ability to have telehealth to prevent that, probably more in the primary care, but it's often in the mental health as well. And that continuity of care, making sure there's follow-up, they have the continuum of care that's provided. And we have some instances where mental health in the dosing facility, they also have a medical and dental provider that allows them to assess the patient and determine if any of their health issues are affecting them and may impact their treatment for the dosing. And then also having access, we see that stigma about behavioral health. And when they go to a crowded waiting room and it's more than just a mental health waiting room, there's that stigma of being part of going in for that big type of treatment. And then the whole privacy for patient being able to be at home and have their care. So now we have another polling question. This polling question is asking if you're prepared for the end of the public health emergency. It's coming up pretty quick, and so I'm just wondering if there's any changes on the horizon, looking at how many changes there are for your organization. Are you prepared for that? And we're looking to see, are you all plan, ready, stock, barrel, going for it, to yes, in process, we're almost there. Yes, started to plan, not quite prepared, and unsure what's going on. And there was one question that came up that says for telehealth, must either the patient or the provider be on site after May 11th? It all depends on the actual service that's going to be provided and what's going to be allowed as in-person or not in-person for that. So, Kim, did you have any other additions to that one? I think we're going to answer some of that as we go through the questions.
Yeah, definitely. I think there was a comment about discussing more about what's changing, and we are getting to that. Some of the other questions are coding specific questions. So those I might have to take and answer those after this session. Great.
How did we do on our polling? Looks like the organization, it looks like they're in process. That's the largest percentage of it. And we got some folks that say unsure related to that. So we'll hopefully go through and work through the actual different changes that are happening coming up. So we organized this based upon the timeline. And we only focused on the mental health type changes. And we may not be touching on some of the questions related to hospital facilities, but we'll do our best to try to touch on as much as we can during this piece of it. So starting with the fee schedule in January 1st, there was a few things that actually immediately went into effect, and that is that exception related to the direct supervision requirement under Incident 2 for behavioral health. And that really is, CMS has cited there's increased needs by behavioral health service and workforce shortages, and that there's hard to find people. And the final rule basically eased the physician and non-physician supervision requirements for behavioral health services. Currently, you can bill Incident 2 to a physician or nurse practitioner or other non-physician provider that's a qualified provider that requires direct supervision by a physician or nurse NPP. That means that they must be present in the office suite, but not necessarily in the room, and immediately available to furnish assistance and direction through the performance of the procedure. And that is allowing auxiliary personnel such as licensed professional counselors, licensed marriage and family therapists to provide behavioral services under general supervision of a physician or NPP. But be aware that CMS did not really define behavioral services by HCPC or CPT of which ones needed supervision or not supervision. And they say that the individual practitioners are the best position to determine whether particular treatment or diagnosis is a behavioral health service, and in addition to that, to also follow a state scope of license. Kim, do you want to talk about the other elements?
Yeah, one of the things I wanted to call out here was the creation of a new code that was effective January 1st. And that code listed there is G0320. And it was created to address circumstances where the behavioral health service was performed by a clinical psychologist or clinical social worker. There are some technical pieces here that are required if you're going to use G0323 for reporting. The biggest one is that it needs to cover at least 20 minutes of service time per calendar month. And then there are some specific documentation components to it. So if you're delivering this service, be sure to document if it's an initial assessment or if you're following up. So it's that ongoing monitoring piece. Behavioral healthcare planning in relation to the condition. So this would include any revisions to plans where applicable. It also includes that time that it takes to facilitate coordinating treatment. So if you're working to set up an appointment for that patient with a specialist or referring them to other providers as well. Lori, anything about the opioid treatment program?
There's some particular changes to the opioid treatment programs. but not really so much related to telehealth, but the fee schedule did noted for some of the methadone pricing and the rate for individual therapy for the outpatient treatment programs. But so we'll talk a little bit about some other things that are coming up in the future that will be affecting it from a mental health, telehealth. So, and then the annual beneficiary consent for virtual check-ins. This one is they have implemented where it's new CMS guidance, which allows a patient to consent to a virtual check-in. The provider must document the consent in the medical record, and the consent is good for 1 year worth of services. So that's something to make sure that you have in place. So just now we're going to go to 151 days after the PHE ends, and there's postponement of telemental health, which was the new rule that CMS had put together to try to support the telehealth and the mental health services. It doesn't mean that there's no reason not to start the protocol, but it definitely says that it's not required in the process, the requirements related to it. We're going to talk a little bit about what those requirements are. Some of the temporary telehealth codes have been extended. Just make sure you keep an eye on the list of the telehealth codes that are allowed and who in the period of time when it's been discontinued. And the CMS's website on telehealth is pretty easy to access, and let us know if you don't have that. They're also reinstating at 151 days the frequency limitation. This does not really apply to all the mental health codes, but it can be seen on subsequent inpatient visits, skilled nursing facility visits, and critical care consults. We just thought it was important to think about limitations and how the Medicare will deny something if it exceeds that limitation. And if that's something for some reason shows up on any of your denials, you'll want to make sure you dig into it and find out why they did that. And then through the end of 2023, there's quite a big list of things that are actually going to be extended or going to happen at 12/31/2023. There's going to be, there's some services must be furnished under direct supervision of a physician or a practitioner. And for Medicare purposes, that direct supervision requires supervising physicians or professionals to be physically present in the same office. The supervising physician need not be present in the same room during their service, but immediately available, as we talked about on the previous. Among the PHE waivers, they temporarily changed that direct supervision rules to allow supervising to be remote or use real time, but that will go away. CMS rejected those proposals to make those permanent, so will expire at the end of the calendar year, so be prepared on how you're going to handle that down the road. There was a question about telemental. We'll touch on that in a little bit. So
yeah. There are a bucket of changes that are happening at the end of 2023. I'm going to touch on a few that are related to coding. The first one really being about modifiers. I don't know about you guys, but it's been super difficult to keep up with all the modifier changes. CMS has indicated that at the end of 2023, starting 2024, modifier 93 will be the one that will be used to report any audio-only services. Now, if you are in an RHC or an FQHC, there may be some different guidelines. So they may require modifier 93 or modifier FQ or both. Same with the place of service. There's been a lot of changes around which health plans accept which place of service. So here, I think place of service 2 is what CMS recognizes. Other insurance plans may recognize 10 or 2. It just kind of depends on how they have structured their reimbursement. We talked a little bit about some of the flexibilities that were allowed during the PHE. Some of those go away at the end of the year, and some will be made permanent, and we'll touch on those in the next slide. CMS coverage guidelines are interesting. And I think the important thing here is that not every payer follows CMS coverage guidelines, and not every payer has tied those guidelines to the end of the PHE. So while we see these changes happening in Medicare, it's not necessarily transferable to other insurance plans. So for example, your state Medicaid program in a lot of instances is expanding that coverage where Medicare is contracting it a bit. Same applies for Medicare Advantage programs, and commercial programs kind of offer what they will with these types of benefits. So one of the things to keep in mind is how those guidelines will impact your payer mix. An excellent resource for looking at things at a state policy level is the Center for Connected Health Policy. They have done a fantastic job at laying out the requirements for each state. So, take a look at your payer mix, take a look at the states that you're practicing in, and reference that website for kind of what those state-specific rules and regulations are. Well, Lori, what about this home addresses for providers?
Yeah, so during the PHE, we know many of our providers were working from home and rendering telehealth services. And although they were providing the care from the home, they didn't have to put the home address on their Medicare enrollment or on the claims. So, but they could continue to be billed from their enrolled location. So when the PHE ends, this waiver will go away, and we'll have to go back to ensuring that we're billing, appropriately accordingly to the place of service. Then on the opioid treatment programs, there's some flexibility for opioid treatment programs so you can use that telecommunication for initiation of treatment with, and I don't say this very well, but can you say the word? Buprenorphine. Thank you. I have trouble with saying certain things. They basically, SAMHSA generally requires a complete physical evaluation before a patient begins a treatment. However, during the PHE, the DEA and SAMHSA allowed the outpatient treatment programs to initiate treatment using audio video and audio only communication without first conducting an in-person evaluation. So this will end as of 2023. The final rule also modifies that opioid treatment program intake add-on code to allow the use of add-on code when the initiate treatment is furnished via two-way audio video communication technology to the extent that it helps initiate that treatment. Per CMS, that add-on code will it was only technology, audio video. When audio video technology isn't available is when it's going to be allowed. And so on the, if you go to the CMS's website and Medicare fee-for-service payment and opioid treatment program, they list the requirements. And, if you can't use the technology of audio video and the patient's not able to, then you can use the alternative. You need to document what the reasons were behind that. And I'm just going to touch on payment parity, but we continue to see that there is payment parity, across this, from Medicaid to Medicare and across the payers. But we know that for those type of parity that was put in place by CMS during the PHE in non-facility distance site settings, those have been extended through the end of 2023. By using that non-facility place of service code when telehealth services are not provided to patients in hospitals, clinics, or other facilities. So you'll have to look at your rates are going to change January 1st, 2024. Okay. It's a lot of information, a bucket of information, as Kim said. So now through the end of 2024, so couple of years, year and a half out, we're going to start seeing some other things that are going to change, and where the flexibility of where the patient receives the care and where the service originates. During the PHE, the definition of that originating site was expanded to mean any site in the USA, including a person's home. And that was prior to PHE, the originating site only included the home in certain circumstances. So through the end of 2024, telehealth service can be rendered regardless of the patient's or provider's geographic location. Although, depending upon any other legislation that might happen, after December 31st, 2024, those telehealth services cannot be provided in a patient's home or other non-traditional originating site, with exceptions of treatment of substance abuse, mental health, ESRD, and acute stroke. So audio-only technology, any type of non-behavioral mental health services cannot be delivered using audio-only communication platforms. We'll talk a little bit more about that telemental in a few minutes, but that's where they're talking about the ability to do the telehealth service and do that from their home. So we just want to make sure that, because I just was going through the fact that you can do the originating site for substance abuse and mental health. Also, when you do have the audio only for behavioral health and mental health services, it's important to include that modality of treatment in the documentation of the services so that you can say this is why we did audio only. And then there's expanded list of the healthcare professionals can furnish, that we're able to furnish distant site telehealth services. That will remain expanded through the end of December 31st, 2024. And then after that, it will change. And then for FQHCs, or federally qualified health centers and rural health centers, they can serve as distant site providers for telehealth through the end of this year, that 2024. The last one here is a delay of a requirement of prior in-person visits. This is really an in-person initial visit that's within 6 months of the initial behavioral health and mental health service, and annually thereafter will not be required through the end of 2024. After this, for any non-rural or qualified originating site, absent any legislature, in-person will be once again required within 6 months. So that's quite a bit of stuff that we went over on that slide, and quite a bit of information. We're getting lots of questions, and we're hoping that we can respond back as we get through these slides here. Maybe we can answer a few of them and then move from there. So from Medicare telehealth coverage, it's been clear in a lot of information that we've seen that state licensure, there's CMS said boldly in their FAQs for the PHE that, not boldly, but didn't bold it, but they did say that CMS will defer to the states on the billing for patients in another state, licensing and things like that, scope of license. So I do know there's a lot of states looking at legislation related to their scope of license, as well as telehealth and how that can be provided to patients. So I'm going to pass it off to you, Kim.
Yes, we've talked a lot about things that are changing and going away. Here's some good news. We have some things that are sticking around. So CMS expanded the coverage for telehealth services, including audio only for treatment of mental health and substance use disorders. So those two things are going to be important to keep in mind as we start looking at risk, that it is specific to mental health and substance use disorders. I know this is going to come as a big help to providers. It'll help with the evaluation and treatment of patients when they're located in their homes. So under the rule, Medicare will cover telehealth while it's delivered to a patient located in their home if conditions are met. So there's always an if with CMS. The first one is that the practitioner has conducted an in-person exam of that patient within 6 months before the initial telehealth service. So this is your new patients. They have to have an exam 6 months prior. The telehealth services is furnished as part of that diagnostic and evaluation and treatment of a mental health disorder, and that the provider conducts at least one in-person service every 12 months following that initial telemedicine visit. You'll notice here on this slide that in parentheses we do list some exceptions, and there are some limited exceptions where the annual in-person visit could be waived. One exception where this might be appropriate is if in discussions with the patient, it may worsen their condition to have them come in for an in-person visit. Whatever exception to this requirement you're looking at, it is going to be important to document the reason why. When capturing this information, document that the discussion has taken place within the record, and the reason for delaying the 12-month visit requirement. So another hot topic, and I know we're all anxiously waiting to see if the DEA proposed rules on prescribing will be amended or codified into law. The two proposed rules cover prescribing through telemedicine, and the proposed rules are here on the right-hand side of the slide, along with the table here that the DEA has provided around prescribing. So in particular, there's two proposals. The first one is really addressing the prescribing of controlled substances when that provider and patient have not had an in-person medical evaluation. So currently it's allowed because there is a qualified exception clause in the rule, but that stops on May 11th. So this first proposal is really looking to create a narrow definition under an existing exception called other circumstances. So what this rule would do is allow for a 30-day supply of, again, non-narcotic medications. Beyond a 30-day supply, there would need to be an in-person visit. The second rule proposes a carve-out for prescribing buprenorphine. Similar requirements around having an in-person visit. So these were the proposed rules. The comment period for this particular set of proposals has ended. Not surprising, I'm sure, to know that the DEA received a significant number of comments. At one point, I heard it was over 30,000 comments related to the proposal. Most comments were related to how this is going to impact patients. It was expressing concerns over continuity of care issues, access, and just in general, the short notice that these rules require the providers to get those patients in for their in-person visits. So in addition to having an impact on opioid use disorders, the proposed rules will have an impact on other medication-assisted treatments. So those treatments that are geared for other substance use disorders, serious mental illnesses, or co-occurring disorders. The requirements for that in-person visit are really going to depend on when that individual was prescribed medications. So, and I've outlined the timeframes there. So this is one area where really you want to create some kind of action plan now. We want to have a strategy in place for, one, how we're going to identify patients that need to come in for an in-person visit, and two, how we're going to schedule them all. There are different timeframes depending on when the prescription was initiated. So you'll need to match up the patient with the time frame. So there are a couple different strategies for accomplishing this. One of them is, getting a qualified telemedicine referral. So this is where your patient has an in-person visit that's conducted by another provider face-to-face. And during that encounter, the provider is referring that patient to you for services. Another is kind of a hybrid approach, which I think is really interesting, and love to see how this ends up playing out in practice, is an in-person visit. So your patient is seeing another provider in person, and at that time during that encounter, the telemedicine provider is present virtually in the room. And so there's like a three-way conversation and referral happening at that point. In either case, however you're getting that referral, either you're seeing the patient in person or it's coming from an external provider, you'll need to have some documentation in order to support the service. One is that if you're receiving a referral for those services, that provider who refers the patient needs to be registered with the DEA. So you'll need a process for capturing that information. Having the in-person visit is just kind of one component of how these rules will affect your practice. Should they go into effect, there's going to be additional documentation that's required, particularly around prescriptions. So you'll need to have a way to identify that a prescription was written as a result of a telemedicine visit, and that you've checked the state prescription drug monitoring database before writing the prescription. And then you'll need to have a detailed log of all telemedicine prescriptions that'll need to be maintained. And under this rule, if it goes through as written, that documentation will have to be, quote unquote, readily available. So it's something to consider now, because often these records are segregated from other records within the medical record. So thinking about how you'll be able to readily identify all the medications that were written as a result of a telemedicine visit, and that the state drug monitoring database has been checked, and that a referral was received from a DEA licensed provider. All those things will need to be considered. And these, the proposed rule is closed for comments. We're expecting the DEA to respond soon. They have 41 days, and that takes us up right to May 11th. So not a lot of time to, change gears here. So now we have a polling question here around how your organization has identified or assessed risk associated with a telehealth program. So do you do that regularly? Maybe infrequently? Are you planning on it but not sure? You haven't started? So I think one of the things that I've noticed here, Lori, is that programs that were established during the PHE kind of went in fast and furious. And I don't know that there's been a lot of downtime, for lack of a better word, to sit and look at what processes were established, and if going forward they're going to be appropriate and meeting all the additional requirements that we had pre-PHE. So.
Yeah, I agree. It's been quite a flurry for everybody. In fact, I know that several organizations we work with have had to go back and make some corrected claims as well because of just the changing requirements and the way that things were documented. So really looking at what's going on related to your risk perspective.
Mm-hmm.
So, yeah.
Yeah, so unsure. I think that's not surprising. I mean, like we were just mentioning, a lot of this was kind of fast and furious. So now's a good opportunity to take a step back and look at what processes are in place. And then as we kind of shift and talk about what the risks are and strategies, what do you consider to be your greatest risk now? Is it documentation, privacy and security, coding and billing, scope of practice? Maybe unsure, or if you have another, it would be great to hear what those are in the comments here. I think from my perspective, what I have seen is that especially around behavioral health services, is clinical documentation can be a source of great risk, ensuring that documentation supports the service and that that diagnosis code that's really important is clearly documented.
I do think there's some privacy and security out there that's going to come around. I think you've seen a lot from the Office of Civil Rights about different security things, and but it's also seen some issues where providers have said there was 5 people in the room and I couldn't get that person to go into a separate room.
Yeah.
And so a bit challenging with that, but sometimes they say it's great. I can see their environment behind them. So I know now why they fall all the time, those type of things. Okay.
Yeah, that's an excellent point.
This looks like they're right alongside you.
Yeah. Interesting. Well, hopefully we have some tips here for you.
Okay. So now we're going to touch on some risk, and I know we're getting short on time, but I think it's really important to always bring up the Office of Inspector General's work plan items, and they have 6 items on their listing. We tried to capture it. Whoops, it has this method of going back and forth on this slide, so I apologize, everybody. But they, one of the things that they are, they just added another one related to remote patient monitoring that might not impact all of your organizations, but that they are going to add that as one of the areas that they're going to audit. One of the things I wanted to bring out is that the OIG did release a report in November last year about, it was a study, it was actually dated 12/1/2022, where they looked at all their carriers, the people that are their contractors that are doing the claim processing, and particularly their OIGs for Medicare, TRICARE, et cetera. And when they looked at the data, they said there was a variety of telehealth services were available. They identified some high volume billing, duplicate claims, and inappropriate charges for the expensive level of telehealth services. At the same time, there's another group, I don't know if everybody's heard of them, but they're called the Pandemic, I can't say it, Response Accountability Committee's Healthcare Subgroup. It's called PRAC, Healthcare Subgroup. And on there, they also reiterated those issues that they found. They went back and pulled a different sample. This slide here is an OIG data brief that was released. And as a data geek myself, I appreciate having elements that I can go back and look at some of my data to say, do I have some of these same risk areas? They took data from March of 2020 to February 2021 and used these 7 measures and identified 1,714 providers. This is just not focused at mental health. It's across all providers that were doing telehealth and billing to Medicare. And some of the areas that they have that they're planning on having the OIG CMS do is monitoring and targeted oversight of telehealth services, provide education to providers, transparency of incident too, because they had some challenges with the data, and identify telehealth companies that bill Medicare because they don't have them all set in place, and then follow up on providers that were identified in the report. I see it as a great data tool, and it's in our materials for you to reference and actually pull the report down. It's kind of an interesting read from again, a data geek perspective. So now just kind of talking about risk areas, and as Kim was talking about a few minutes ago, is just a lot of changes to our workflows. And did we actually do those in the step-by-step process that we normally do, and it's not a PHE? Probably not. So it's time to go back and really dig into those operational workflows and see if there's something that might be a barrier in preventing it from being able to do the proper billing and supporting medical necessity, meets those quality standards. And then within that operational workflow, there's look at the training of the patient, the non-English speaking patients, behavioral health and rural health populations without broadband. So kind of what is that operational workflow and how did you adjust those for those various populations? The service doesn't meet the quality and service expectations. Organizations are looking at that not just from a chart review from a coding perspective, but also to see if it really met that quality and service that should have been provided if it was an in-person visit, and kind of through their peer review or other ways they're digging into that. They also talk about some of the things that we did was the supervision, and that changed during PHE. We know it's going to go back. So how do we make sure that those controls are in place to ensure that we can trace back that somebody was supervising that person if you're going to be doing any type of billing for those services? And the last one here is a proper establishment of practitioner and patient relationship. There were several cases. One in particular was the DOJ had a takedown, which they do, and they find several of the same issues occurring. They said that in those cases during that takedown, there was a lack of meaningful interaction, I'm quoting here, lack of meaningful interaction between provider and patient and the ordering of medically unnecessary products or services. This was where they were doing inappropriate patient marketing, et cetera. The patient received a cold call, and then the patient expressed a willingness to speak to a provider. There was no relationship there, and they felt that that was not enough to support the medical necessity. And then just this slide here is just to show you the Center for Connected Health Policy. Love this site, spent a lot of time on here. They do a great job of keeping things up by state and other policies. Kim?
Yeah, so the link to that site will be available in the materials. I know we've had a couple of questions from folks asking for the link. Definitely recommended here. So kind of continuing on and looking at what are some of the risk areas and things that you should be considering as we roll out of the PHE. The first one really being training. It may have been hard to see, but that OIG data brief calls out training as a recommendation. It's really going to be important to provide training as these changes roll out, because these changes are really going to be varied among the payers and the states. Having a single source of truth for staff to rely on will be helpful. Even having a single point of contact that is going out proactively and looking to see what changes there have been will be helpful too. So not only is it training, it's keeping track of that training. You'll want to maintain records of when the training was delivered, who attended the training, what the topics were. This is going to be particularly helpful because down the road, the guidelines that you're using today are not going to be the guidelines that apply May 12th, and they won't be the guidelines that apply in 2025. So having a record of what was in place during specific periods of time, that it'll save a lot of work in the long run. So monitoring processes related to telehealth, we touched on this a little bit. Really this is getting to how are you monitoring not only the use of telehealth, but you're ensuring that the coding is accurate and that the documentation is present. There's no way anyone can audit every single thing that comes across. So thinking strategically about setting up system edits to flag specific accounts for review is a strategy to monitor services. So we have monitoring services, and then we have the monitoring of the ever-changing regulations. It's hard to keep up. I know some of you have responded in the comments that it's a lot, and agreed, it's a lot. One of the things that we want to consider is, especially around, I think, the DEA proposed rules. When those rules go into effect, assuming there's no amendments or delay, how quickly can your organization implement those changes? So that's what the DEA rules. What about a health plan that decides to switch from we accept place of service 2, now we only accept place of service 10. And that's happened quite a few times over the last couple of years. How quickly can you make those changes so that you're billing out appropriately? And when you're making those changes, are those changes being documented? So just like with training, you're going to want to have a record of what your system looks like at that specific period of time. Privacy and security, definitely a risk area there. There's a 90-day transition period for providers to come into compliance with HIPAA. One of the things to think about here is looking at your processes for communicating with patients. Make sure you're not using messaging apps or unsecured email. And then one I think that gets overlooked from time to time is accidental disclosure. So this is where documenting who is in the room with either the patient or yourself as a provider is really going to be important. And as all of these things change and things come up, policies and procedures will be extremely important. So how are other folks out there doing it? Here is an example. At the link here will bring you to this resource, and it's a great resource. They have not only this out there, but several other guides as well. It's a way that they're tracking the changes and communicating around key dates.
Sorry to move you fast, but we only have about 5 minutes left. So I'm just going to go ahead and pass it off to you to just touch on briefly on the next couple bullets so that we can make sure that we finish up. So
already covered modifiers in place of service. I think one of the things I wanted to touch on here is this fourth bullet around not a covered service. So we've been looking at telehealth records for the last couple of years, and this is something that comes up fairly frequently related to how systems are set up. A really good example here is a nurse or a nursing staff member will pull up the medical record to document a phone call with a patient, and they accidentally choose a template that is specific for telehealth, which is tied to a charge. So nurse is documenting their phone call with the patient, accidentally dropping a charge, and if there are no edits in place or no level of review, that is getting submitted for reimbursement. So it's important to look at any time you have a auto generated charge capture to make sure that it's appropriate. Consents are huge. Lori mentioned at the top of the presentation that CMS has identified that a consent for 1 year would be appropriate. Now, that's CMS's regulations. States have different regulations. It's best practice to get that consent at every visit. And the reason for that is it just provides documentation that there was an understanding between the provider and the patient, that it's delivered via telehealth. It's also a great place to capture any exceptions where you need to document why a service was performed as audio only. Remember, those are limited circumstances. That's a great place to capture it. So best practice to have that included. When looking at documentation, there's several items here to give you just some guidelines on where to start. I think the one I want to spend time on is really around diagnosis code. And the reason for that is, back at the beginning, we were talking about how CMS will allow for services to be furnished based on diagnosis. So look at your system, make sure that your visit templates are not pulling the primary diagnosis code from a problem list, and maybe that's hypertension. We're really looking to ensure that that documentation and that primary diagnosis code supports the visit. In fact, CMS stated they're going to monitor for this. They will use the information that is submitted to them through claims and look at the diagnosis code to make sure that we have a matching diagnosis with a appropriate telehealth service. So I anticipate there will be future audits in this area for sure. So important one to take a look at.
Thank you, Kim. And thank you for rushing through those couple slides. And we apologize that we didn't get to go over every bullet, but there's so much information, as you could tell from just the beginning, and apologize for that. But we'll be more than happy to talk to individuals and get back to people about the various questions that have come through, and we'll do it as quickly as possible. So from a summary perspective, we just know that it's ever changing with telehealth, and to keep up with the different regulations and changes that are going on. Also making sure we look at the telehealth visit, do an internal audit, check it the whole workflow, not just the coding, make sure that that's not a template issue or something else that's happening, or an auto-populated type situation. And then trying to do some data mining to assist in kind of identifying any outliers. We notice that a lot in some of the information that when we would get the data to do our sample selection, to do coding audits, we see that there's the things that are supposed to be telehealth aren't telehealth, or a variety of things, and just trying to find the right sample. Again, it is not an easy thing to pull. And so look at your organization's post-PHE, how your workflow and regulations will change. And hopefully through through this long, lengthy slide deck that we went through, that you got a bit of nuggets and you can move forward with that. Now I'm going to hand it back to Amy so she can do her quick ends.
All right, thank you, Lori and Kim, for a really great presentation today. I also want to thank our audience for being engaged and submitting your questions to help guide today's conversation. If we didn't have time to answer yours, we will do our best to follow up with you after the webcast. Feel free to reach out to our presenters if you have additional questions. Their contact information is located in your console, as well as in the slide deck, which you can download now from the handouts window. Also, let us know if you'd like to set up a separate call to discuss this more in depth by dropping a note in the Q&A window. If you met all CPE requirements, your certificate is available to download now in the CPE progress window. A copy will be emailed within 2 weeks if you have difficulty downloading it now. And finally, here's a link to an online survey for today's presentation. And thank you for joining us. Take care, everyone.